Well, I am excited to be sharing on the topic of lifestyle medicine. And I think one of the most fun things about today's talk is that it gave me the opportunity to dive deeper into some areas that I wanted to go deeper into. Sometimes you don't get that opportunity. Sometimes you get told, you're going to do a talk on, X, would you be willing to do it? But in this case, they said, whatever you want to talk about. So I debated about doing something that I'd already done before that I'm interested in, or doing something new. And then in the next couple of weeks, I happened upon a couple of very fascinating articles. And I thought, what if I did kind of like, latest literature that's coming in? What is the newest, information? So this is not like a synthesis of teaching you the principles of lifestyle medicine. This is just, hey, here's a fascinating article, something that I took away from it. It made me think about these particular things, maybe think about maybe a hypothesis or a mechanism. Maybe it explains something we didn't understand before. And so I hope it'll be enjoyable and fun for you as we go through this today. So I think it's always good to ask, the first question is, why lifestyle medicine at Loma Linda? Well, I was just chuckling with some of my friends in the front row here. I always appreciate people willing to sit in the front row. I usually sit in the back, so I don't even walk the talk, but I'm glad for people who sit in the front row. And they said, hey, I used to work in this building. So, lifestyle medicine has been part of Loma Linda since the very beginning. So this building was purchased in 1905 by the founders of Loma Linda, and it was a financially failing resort property. So if you weren't aware of that history, it's just a fascinating piece of our story, and located on the top of the hill over here. And so this was where we got our start. And I'm sure all of you have some connection to Loma Linda in which you're aware that we value a faith-based approach to our care. We're a Seventh-day Adventist institution. And core to that here, as well as globally, is the principles of Christian service, of caring for our bodies, because we want to be able to use our energy, use our efforts, use our competence to serve and to bless other people. So this Bible verse about knowing that our body is the temple of God and caring for it has been embedded in who we are and in our culture since the very earliest days of Loma Linda's inception. So fun pictures from the past. This is from that original building. Individuals taking their meals together, high quality food, getting fresh water to drink, outside having exercise, hydrotherapy, just all different ways for people to become healthier in the days before we had advanced medications and procedures like we do now. So in the early classes for our medical students, 1906, some of the classes that were available to the medical and nursing students, gardening, cookery. I love that, cookery, not chef, not being a chef, not culinary medicine, cookery. So, we change and evolve over time. That word has changed. We don't use that anymore. Hydrotherapy. So these are some that just stood out to me as being particularly relevant in the world of lifestyle medicine. And when we talk about a treatment triangle of care, within our medical world, we really have a lot of expertise in these top areas of surgery and prescription. But sometimes the base of the pyramid is not built at a robust level in our training. And so this is where I have kind of gotten excited and passionate about learning about these areas, spreading the word, sharing with others what we're learning. And I think this is important because 80% of our chronic disease burden is directly related to lifestyle choices. Now, that doesn't mean that 80% of diseases will go away if we solve this problem and create a perfect base to this pyramid. That's a little too rose-colored glasses, but it does give you pause. When you say 80% of anything is due to X, we should sit up and think about what can we do about fill in the blank, the X, right? This is important things to think about. So how can we build a better base for this pyramid with our lifestyles to support the physiology, the prescriptions, the surgery that is so important to medical care? All of these components are critical. So we've found that by doing the lifestyle pillars, which American College of Lifestyle Medicine has coined, they said there's 6 pillars or key areas of lifestyle medicine that are often interrelated, often they impact each other, but they underpin all of this medical care. So if it's not optimized, it's going to be really frustrating to be caring for that patient. The patient themselves is going to be frustrated. They're not going to be getting the outcomes that they would like to see. But if they're aligned, we can get the best possible outcomes for the patient. And you can see here, again, that data, that this could probably reduce risk by 70 to 90% for most non-communicable diseases. And we focus, sometimes it's a criticism of lifestyle medicine. All you folks do is talk about nutrition, sometimes physical activity. And there's 6 pillars. I think it's a fair criticism. But why do we emphasize the nutrition and the physical activity so much? Well, if you look at this graphic from 2018 about risk factors and cause of death, you'll see that dietary risks is the top one. It has risen above tobacco use. So let that just sit for a minute. It has risen higher as a risk factor than tobacco use. Number one. So just think about that. This is why we talk about the nutrition part a lot. You'll also see a little farther down on the list is the low physical activity. So of the 6 pillars, those are the 2 that have made this list of the top risk factors for death. So I think this is just to point out why we emphasize this, why we pay attention to it, and why when somebody opens their mouth like me, give them a microphone and they start to talk about lifestyle medicine, why we often default to talking about nutrition. The other parts are incredibly important. I'm going to touch on them all today, but I'm going to try to distribute my time on the research and the literature similar to the emphasis that we're seeing in the risks for death. So let's start with nutrition. This was the article that got it all started. This was the article that I saw this past fall or summer and said, I have to talk about this article sometime. This is so fascinating. So many research articles have questioned the potential harm of high fructose corn syrup or highly processed diets, right? I'm sure all of us are aware that unless none of us are ostriches to the point that our heads so far in the sand that we don't have some awareness that processed diets are a problem. So people, even if you don't care about this, you're not working in this area of medicine, you've heard about this. And it is well known that highly processed diets and foods are not beneficial to health. And some people have raised the question of whether it's easier to gain weight on a highly processed diet than on a low processed diet. And we know that a calorie is a calorie, but then a calorie is not exactly a calorie. Some calories get absorbed more easily than others. Some calories seem to contribute to weight gain more than others. What is this? We're trying to sort this out. So this study by Nunez, which was published in Nature last year, they looked at absorption of nutrients and the impact of fructose in the gut. So you remember villi, those are those little finger-like projections that are showing here on our screen. They lie in our gut. They absorb nutrients. And normally the cells at the very tip of that villus are hypoxic and they die. And that limits the lifespan of that villus, how long it's going to grow, the length of it. And that's because they have energy depletion, they have oxidative stress, all these different things that cause those cells to turn over, and it limits the length of that villus. But when fructose is present, those hypoxic cells live longer. The villus grows longer. Okay, well, longer villi, if that didn't result in anything else, who cares, right? Well, what they found was that it enhanced absorption of dietary fat, even to the point that normally you would need this enzyme called lipase to be able to absorb the fat. These longer villi were able to absorb fat even without the lipase present. And it was associated with a rise in blood lipid levels that was able to be measured. Isn't that fascinating? Very fascinating. So, okay, I just have to tell you about this. It was so interesting. Next, on the same thing, but switching to a different study, ultra-processed diets, unprocessed diets. Another team looked at this and they said, let's take 20 adults in an inpatient lab, a food lab, and we're going to give them an ultra-processed diet. We're going to give them an unprocessed diet for 14 days each. Then we're going to cross them over. We're going to see what happens. They did not dictate how much food everyone had to eat. They just presented the food to them and then they were able to eat freely. So ad libitum intake of the food. And the diets, fascinatingly, despite the fact they were ultra processed and unprocessed, were matched for sugar, fat, calories, fiber, macronutrients, etc. So I'm glad I didn't have to be the dietitian to come up with those menu items. That would have been a trick. So then they, divide them out and they look to see how many calories did people consume. They found with the ad libitum intake, the individuals on the ultra processed diet consumed 500 calories more per day. That's that blue line going up, with body weight. It's the ad libitum blue line that's higher than the red line. They took in 500 more calories per day. That is significant. If a calorie is a calorie and you just add that up really quickly, then all calories are equal, that's a pound a week, right? So it might not have worked out exactly that way, but it's still a fascinating thing to think this is what they were seeing. And they saw body weight changes that went along with this intake. So after looking at this, they said, why? What is the mechanism behind this? What is making them like this food better? So they looked at pleasantness, they looked at familiarity, they looked at hunger, they looked at fullness, they looked at satisfaction, they looked at capacity to eat. All were the same in both groups. They looked at eating speed or eating rate, and this is what they found. Individuals eating the highly processed, the ultra processed diet were taking in 17 kcals per minute. On the other diet, they were taking in 7.4. Really, that's a significant difference. So, and previous studies by others have demonstrated that higher eating rates can result in increased overall energy take, and that a 20% change in eating rate, this is more than double, but a 20% change in energy in eating rate can actually impact energy intake by 10 to 13%. So other studies have created this link and this connection to say, yes, eating rate can actually result in greater energy intake, supporting what they found in this particular study. All right, I'm going to be brave here. Another area within nutrition. What do bears and pregnant women have in common? I know that's a dangerous question, right? But I feel like I have been a pregnant woman 3 times. So it's okay for me to ask this question. A gentleman might not be able to ask this question, but I can ask this question. So there are certain physiological states in mammals, such as when a bear is not hibernating, or when a woman is in advanced pregnancy, where they have a very different microbiome. So switching gears, we're talking about microbiome now. Okay. So they have a different microbiome, but they don't have metabolic abnormalities associated with that changing microbiome. So we've learned that there's this back and forth between, the microbiota, the metabolism, all of these different pieces interacting. And the human gut typically has 2 types of phyla. So within the world of microbiome, Firmicutes and Bacteroidetes. So those are the 2 main ones. But within those 2 phyla, you have a whole bunch of taxa and species and everything. Those can change very rapidly. And what they found is that within 1 hour, a bacterial colony can double. Within 24 to 48 hours, it can be completely purged and replaced, which means that even though these 2 phyla might stay relatively the same, we can see significant changes in a short period of time. And that's what we're going to talk about next for the next couple of slides. So COVID connection and gut connection. On the left, in figure A, you'll see the colorful bars, and they're just showing, you don't have to memorize these, you don't have to see the small print, but basically it's just demonstrating that different phyla and different taxa of the bacteria are distributed in various conditions related to COVID-19. So the one on the far left is COVID-19 patients who are hospitalized. The one in the middle is those who've been discharged and considered recovered. They're now testing negative by PCR. And then the next one is those who are non-COVID, just as a comparison. So looking at other groups of patients to see how their distribution is different. Figure B does something very similar. They're basically mapping out composite measures of the bacteria. And the main point is you can see there's kind of different foci there. There's different areas, different distributions that they divide these groups out and they say, okay, the one group is people who don't have COVID-19. The next group is people who had COVID-19 and received antibiotics, because we would expect that to impact the gut. And then the other group is people who did not have antibiotics. So just showing that there is a differential distribution in these different conditions. All right, now how about this? Disease severity. In this particular slide, they were able to show that the severity of the disease was actually correlated between gut microbiome and plasma concentrations of inflammatory cytokines and blood inflammation markers. So you could look at somebody's gut and you could have an idea of what would be an associated cytokine level that might be released. And that this correlated with the disease severity. And you can see each of these circles is basically showing with a COVID-19 group of patients, did their gut bacteria look different? And the answer was yes, it did. So then they said, well, do these changes persist? What if it's just in the hospital? So this one is looking at about 30 days out. What happens after discharge? Could this be implicated in things like long COVID, post-acute COVID? We don't know all the answers yet, but it raises really, really fascinating questions. And it tells us that the dysbiotic gut composition in patients with COVID-19 persists even after the virus is cleared. Now, this is the most, I explained everything else up to this point about the COVID and the gut, just so I could get you to this slide, because I think this is even more fascinating. We have all these predictor mechanisms for COVID-19 severity, right? If I pull up my LEAP chart here at Loma Linda, like the top left of the screen says, if this person gets COVID, this is their risk on a scale of 1 to 10, high risk, low risk, medium risk. So, and it's based on a variety of different clinical factors. Well, this group, Ward and his team said, let's look at the gut microbiome and can we predict how severe COVID would be in this patient before they have disease? Could we predict what severity of disease they're going to develop? So this was super, super fascinating. And I have to say, this is a preprint. It hasn't been peer reviewed yet. The reference is up here, so you can look at it yourself and decide if you think it was well done or not. But I just thought it was absolutely fascinating. They found that when they did a combination of the bacteria plus clinical criteria, they could get anywhere between a 92 to 96% accuracy of the severity of COVID. And they actually also did tongue, because wouldn't it be easier to culture the tongue than to get a stool sample? So they looked at that. 84% from the tongue accuracy. This is amazing. Like we're doing all these in-depth clinical calculators, and basically we just need to look at people's poop and what's in their mouth. It's fascinating. Okay, that's the end of that one. This is a fun ride, right? We're on to a new thing. Physical activity. You ready for physical activity? Bone mineral density in postmenopausal women. This was also a fascinating study. So we've all thought for a long time that exercise, it stresses our bones, should have some benefits for bone mineral density, right? Like, yes, we all would agree that there's probably some connection there. However, when it comes to looking at bone mineral density, previous studies had two issues. One, they were not long enough. They were inadequate length of time to detect differences, because a bone remodeling cycle takes about 4 months, but it takes another couple months to be able to see that radiographically. So most of the studies weren't that long. Number two, they had an inadequate dose of training to be able to see a benefit, right? So if you don't want to find a difference and you're a researcher, maybe you're paid by somebody in industry, how do you set up a study that's not going to find a difference? Well, you inadequately dose it. And then you're able to say, oh, there's no difference, right? Well, I don't think that was the intention in the previous studies. I think they're just learning. They didn't know. And so it was inadequately dosed. But we're all a little scared, right? Who wants to have an elderly patient fall, die, have a compression fracture, have a hip replaced, something major because they had low bone mineral density and you put them in some aggressive training program, right? So that's a scary thing to think about. So I think that's part of why, as a profession, we've been hesitant to get out there and say, let's do something really aggressive and see if it will impact these patients favorably. So let's see what they learned. Well, first of all, I'm going to give you the anecdote that's interesting first. They got taller. The people in the experimental group got taller. Now, it wasn't a lot taller, but it was statistically significant. And we all know that generally as we age, we do not get taller, we get shorter. So that right there got my attention. I was like, I need to know more about this article. I want to explore more. So looking at this, they then said, let's look at 8 months and let's look at their DEXA scans and a quantitative ultrasound and see what happened there. So in the control group, the measurements stayed roughly the same or worsened. And in the high intensity resistance training group, the measurements from beginning to end of program either showed no change or improved. And then I'll have another slide that shows you these for the DEXA scan, because those were more favorable. So this was fascinating. The dark, let me just make sure I'm saying the right thing. The lighter gray is the control. So the ones mostly going down, or that's the control. The darker gray ones, or the black ones going up on figure A, so on that side, were the measurements for the bone mineral density. And then the final one was called speed of sound, which is a quantitative ultrasound measurement looking at how quickly the ultrasound passes through the tissue. So more dense tissue passes through faster. So here you can see largely improvements, and definitely for their physical activity. So that's on this side, all these little ones on figure B that say like LES and BES, that's like leg extensor strength, back extensor strength. So it's all these physical muscular measurements, and they were improving more than they were in the other group. Now, in this case, the controlled group actually had like a very low intensity stretching, flexibility, a little bit of exercise program. So it makes sense that they would have had some improvement, but not as much as the other group. So really impressive findings here. A lot of improvement in the bone mineral density, a lot of improvements in physical fitness. And we all know this is not the topic of this particular article, but being stronger helps prevent falls, being able to get up and move more quickly. We know that speed of walking, all of those different things help us to stay more mobile and functional as we age. So, and most importantly, there was only one adverse event in the high intensity resistance training group. So this is the group that was the experimental group. They had 2,600 training sessions. One person at week 28 had a mild low back muscle strain on the last rep of a deadlift. And when you think about the fact that this was a group of women that were ages 58 plus with low or very low bone mineral density, this is a very novel thing that was happening. You don't usually see advice to send those women out to start doing deadlifts, but that's what they did. They trained them up to it. They got them ready to do it. And they were doing deadlifts in the gym, as well as other much more aggressive, intense exercises. So this person was out for 1 week and then resumed and had no further issues. And they collected falls data and other things, and there was no significant difference between the groups. So from this small study, it's at least initial data to say that it could be a safe way to help improve bone mineral density and maybe help people get a little taller. So, but when we think about exercise, we just talked about deadlifts. Do we think of it as beneficial? Yes, most of the time. Do we think of it as pleasurable, something that gives us joy, that we're happy when we're doing? I will tell you that I'm not that person. Maybe going out for like a leisurely stroll is pleasurable, but when I think of like, I'm all sweaty, I'm going to be riding the exercise bike or running, I'm just like, it's just something I want to get done. Like I want to check it off, my box. I think that's my default thought pattern about it. I'm not proud of that, but I think that is where I have been. I've been trying to change that, trying to have a more positive attitude. And we've heard, it's been known for some years that, for example, next slide, depression can be treated, mild to moderate depression can be treated quite effectively with moderate levels of physical activity, kind of in line with what we recommend for 150 minutes a week of moderate intensity or 75 minutes of vigorous. So this is just to kind of remind you that that article exists. And I think what we're showing here is that there's the control, and then there's what they're calling a low dose of physical activity, the LD, and the public health dose, the PHD. So the PHD is actually quite effective, the public health dose, the 150 minutes per week. and is statistically and clinically significant in treating mild to moderate depression. So we've known that, but it's just fun to look back at this and remember that it's true. And also that when you underdose something, again, it doesn't always work, like the low dose. So we would expect to see that. But what about when we're exercising? So this article stood out to me because they did this new study to look at mood during physical activity. Said, how are you, you're exercising, how are you feeling? And they didn't look just at exercise, they looked at all types of physical activity throughout the day. And they said, we found a link. There is a link between happiness and physical activity of all types, not just exercise. And it's a dose-dependent relationship. They're not saying it's causal, but we do know the rules for causality say that there should be a dose-dependent relationship. So this might prompt us to think that maybe this is something that's headed in that direction. And there were mathematical models showing that more physical activity was associated with greater happiness. It's kind of just another way of saying that dose-dependent relationship. And they measured this with accelerometers and other things and smartphone apps. So I was like, that is so cool. So often when a patient is really depressed, really feeling down, they don't have that energy to get out there to exercise. And I think we need to be sensitive to that. I'm not saying we just bludgeon everybody with the same message, just get out, it'll make you feel better, you know, when they can barely get off the couch. But I think it does give us something to be able to share, to say, you know, there is some data to say that if you are active, you may actually feel happier during those periods of activity. And now that I've looked at the data, I'm trying to reframe my previous perspective and move from this is just something I have to get through to recognizing that maybe I do feel better, and you know, trying to recognize that part of the experience. All right, on to sleep. Sleep is another fun topic. So this article, oh, and I'm going to go back 1 second. The article about the bone mineral density and women, I asked several of my colleagues who are really into these fields, you know, so like we all kind of have our niche area, even within lifestyle medicine. Like I'm a lifestyle medicine person, but I really focus on, you know, maybe more nutrition and physical activity. So, but I have another friend who really focuses on physical activity, Dr. Mock. So I asked him, and he was the one who suggested that article. And then this one about sleep that I'm going to talk about, Dr. Dan Jung, many of you probably know him. He suggested this article. So there was a few, in addition to looking on my own, I asked people, I said, what's the most fascinating thing you've learned in the last year or two? I want to share it with my friends at Homecoming and APC. And so they suggested different articles. So this one was suggested by Dr. Jung. So we have known for some time that there is a link between sleep and dementia and sleep. We know that when people develop dementia, they often don't sleep as well. You'll hear that they have reverse, I don't think they call it reverse cycling, but it has to do with their days become nights, nights become days. It's very difficult for caregivers who are caring for them, who would like to sleep at night. So anyway, there's all these different challenges, right? But does poor sleep predate development of dementia? Is there something that happens in years prior that could be a risk factor for developing dementia? Again, maybe not causal, we're not sure, but this was a prospective study. So in this study, they looked at sleep duration at ages 50 and 60, and then said, what when we look at this person later at age 70, 75, 80 and beyond, do they develop dementia, and what does their sleep look like here, predicting what happens later clinically with development of dementia? So the solid black line in the middle is the hazard ratio, and then the dotted lines are the 95% confidence intervals. And you can see here that short sleep duration, which is the one on the right side of your, I guess it's your left, the left side of the screen for you. Short sleep duration as well as long sleep duration, it gives you this U-shaped curve, right? So there's kind of a sweet spot in the middle around 7.5, 8 hours. That's the lowest risk. A higher risk than that, or higher hours of sleep than that, it's greater risk for developing dementia later in life. So why would they do this, and why would it matter? And is there a mechanism behind it? Okay, so that's the next question. And that brought me to something that I did not learn about in medical school. We all learned about the villi in medical school, but did you learn about the glymphatic system in medical school? I did not. I don't know if they're teaching it currently, but it's a fairly new thing. And I'm going to have two images here of the anatomy, because I think it's very fascinating to learn about new things that we didn't know about the body before. And this is like the lymphatic system of the brain. So it's like, on one hand, it's like, well, duh, of course, there's some system in the brain like there is in the rest of the body. But the fact is, we didn't know about it until recently. So it's maybe not quite so obvious. So it removes waste and metabolites. It helps distribute neuromodulators, glucose, lipids, amino acids, and it's formed by astroglial cells. So here you can see kind of more of a zoomed in image of some arteries, some capillaries, and then this fluid, the blue, flowing around that they call perivascular tunnels. So this is so fascinating that this is functioning, and these astrocytes and astroglial cells create this whole structure. The most important, fascinating thing here, though, is this system functions and does its work when we sleep. It really has minimal activity when we're awake. It's also responsible, they found, for eliminating beta amyloid. So think Alzheimer's. That's just one compound that it helps get rid of. It's very, very fascinating. There's some other data that I've looked at. It's been a couple of years since I reviewed the slides. It's just coming to me right now, stream of consciousness. But it was fascinating to show just one night's sleep disruption and the accumulation of beta amyloid in the brain is actually quite significant. It doesn't mean maybe you can't clear it out the next day with a good night's sleep, but it was a very fascinating connection. So I'll just throw that editorial comment in here as well. So, we don't know, is there some causal relationship between poor sleep at age 50 and 60 when you're not clearing out these metabolites and then developing dementia later? Does it go the other direction? You were always going to get dementia and it's manifesting as early poor sleep at age 50 or 60? We don't know, but these are very fascinating questions to ask and to think about. We do know that immune response can be impacted by sleep. And this is one study that was just looking at a flu vaccine and antibody response at 1 month and 4 months follow-up. And they found out that the 2 nights just prior to vaccination were the most strongly associated with developing an antibody response after the vaccination. So if you got poor sleep, you had worse of an antibody response. Your immune system did not respond as well. If you had better sleep, you had a better immune response. And we talked about those bidirectional connections earlier, right? Like we talk about sleep, we talk about nutrition, but sometimes nutrition impacts sleep or physical activity impacts sleep. Well, here's one of those bidirectional connections that was extremely fascinating. This team, St. Ange, has done a lot of work in the area of sleep, and they found that sleep can drive changes in energy intake. That if you reduce sleep by 4 hours for 4 days, so you get half a week of bad sleep because you're on a tight deadline, it would lead to 300 more calories consumed per day in the following days. And they were able to also correlate this with changes in increased reward center activity in our brain, dopamine and all these neurotransmitters. They're saying we need rewards. And then also the hormones that control our sense of fullness. So both of those were altered and correlated with this change, sleep, and then taking in more calories. And it's so funny, I was reviewing this today. I just returned from an international trip about a week ago. And I was like, oh my goodness, I've been wondering why I've been craving like all kinds of crazy things all week long, but I was very sleep deprived and my circadian rhythms were totally disrupted. And I think it had something at least to do with this. It's a fascinating thing to think about. So some of the things that we know about nutrition and sleep kind of going the other direction are well known. So we know like if you have a really heavy meal, you drink a lot of caffeine late at night, you're probably not going to have a good night's sleep. This team that does a lot of this sleep medicine, I actually started with one article and that led me to another article. Have you ever had that happen? Then you go to another article because you just keep going down the line. Pretty soon you're like, wait, I have to present this to people. I have to back up to just one article or two to share. They found that individuals who had more fiber, less saturated fat, less sugar. I combed through the articles to try to find the specifics on this, but it was really difficult to find cut points. It was more qualitative or descriptive. But what they found was that they had 1.4 times better sleep. They were 35% less likely to have insomnia, and it was a stronger effect than melatonin. And I was like, well, that's fascinating, because I recommend melatonin to patients somewhat regularly as a fairly natural way to help them go to sleep. So anyway, just something to think about, how all of these different mechanisms work together. And then also to think about how this could become a vicious cycle for somebody who's struggling with sleep or has a life situation that prevents them from getting good sleep. Maybe they have to work nights, maybe they have a parent who's ill, maybe they have a child, all of these different things, how all these different pieces can play together and impact their quality of sleep long-term, as well as impact their nutrition status, their weight status, and other risk factors. All right, ready to move on to stress? All right, next topic. So this one talks about stress, and it's almost, you're gonna think I'm talking about nutrition, but it's actually not about nutrition. So for this one, you need to be familiar with these boxes because they're a little unusual, a little confusing if you haven't spent time with them. On this side of the boxes, that inside each of them, so each box represents a biomarker for inflammation. And on this side, on your left, the dot, the point estimate that's there, is representing what that biomarker looks like after a high saturated fat meal or after a low saturated fat meal. So you can see that there's a difference. In every one, they're separated. So high saturated fat is the higher number biomarker, low saturated fat is the lower level biomarker. And the biomarkers that they were looking at were C-reactive protein, serum amyloid A, intracellular adhesion molecules, and vascular cell, like VCAMs, vascular cell adhesion molecules. So these will be very important in atherogenesis, potentially in tumorigenesis, but basic biomarkers. So in this study, what they said was, let's look at some women and measure these levels after we give them the high saturated fat meal, the low saturated fat meal. Okay, great. We got what we expected, right? They're different. Now, what if we look at them after a high stress day? So we're going to give them the same meal, but we're going to do it when they've had a high stress day the day before. And that's what is showing on the other side in each of those boxes where they come together. And in some of them, that difference, statistically significant difference, is obliterated, right? They look like the same response. So stress took what would normally be a biomarker response of, a lower level to a, because it's a low saturated fat meal, and made it look like it was a high saturated fat meal. Isn't that interesting? So fascinating. Just the meal-related differences disappeared. I just kind of feel like I need to sit with this a little longer, but we have to keep moving on. So you'll have to come back to it. All right. So negative things happen, stresses happen, negative life events, and many of them are unavoidable. We can't prevent the death of a loved one. If we could, oh man, we wouldn't have to be here right now. That would be so amazing. But we can't. And, based on that previous slide, we can imagine all of those different biomarkers, how stress could definitely have some far-ranging impacts on our bodies. And there has been, a lot of previous research into this, particularly the connection between mental health and stress or negative life events. So if a negative life event happens, do you develop depression? Do you develop anxiety? Do you develop post-traumatic stress disorder? There's a lot less done on what happens to your body, what happens to your heart rate, what happens to your respiratory rate, what we would consider to be the more physiologic types of processes. So in this study, which would be a great one for anybody who's techie or loves the tech world, loves to learn about those things, this was a wearable technology study. And they said, we're going to track you for a year. And we're just going to look at, I've got my Apple Watch on right now. It's not an advertisement for Apple Watches. I think they actually use Garmin or something else. It wasn't Apple. But we're going to track you for a year. You're going to wear this regularly, and we're just going to see what happens with you over the course of that year. At the end of the year, we're going to go back and look at the data, and we're going to ask who in this large group of people had a negative life event. And then we're going to go to the time period before the negative life event and establish a baseline. of where you would have been before that happened. And then we're going to look after the negative life event and say, what happened? Did you depart from your own baseline? And then we'll aggregate that and study that for the whole population. So the orange is the people who had no negative life events. Look at them, just sailing along, easy peasy, lemon squeezy. We can all be a little jealous if we've had a negative life event recently. The blue is individuals who had a negative life event. And you can see the confidence intervals are so much wider here, right? Some people probably did okay with their negative life events. Some people didn't. They did do a data analysis of the two lines to see if there was a statistically significant difference, because it's hard to tell here. I'll just tell you they were different, even though it's hard to tell for sure if they were. On average, they were different. So then they said, okay, well, let's look within the group that had the negative life events. Some people seemed like they had very little deviation from their baseline. And some people had a lot of deviation for the next 14 days after that negative life event. So the blue line at the top is the people who were the no deviation type group. You know, for whatever reason, they were able to sail through this experience with minimal deviation in their heart rate, pulse rate, heart rate, respiratory rate, physical activity, other things that they were able to measure with this wearable technology. But the other group, the orange yellow line, had a significant difference. They kind of stratified them into these two groups. And then they said, let's look and see what types of coping were used in each of the groups. Is there a difference? Are there certain techniques for coping that might be associated with less deviation or more? So the cluster 0 was the group that was considered to have minimal deviation. And these are the coping strategies that they found were associated with being in that group. Active coping. So as we think, I think that one's more intuitive. You would think if you're really going to this is a difficult thing, I have to get through it, I'm going to engage and I'm going to manage it. You know, you have kind of this aura of control that you're taking over the scenario, even though it feels like an out of control situation. Substance use. So that's interesting. But I can kind of imagine how that could be beneficial, right? In some ways, because you're in this very stressful situation. You want to kind of escape from all the stress of it. You use a substance to help you do that. And so your heart rate, your respiratory rate, everything might kind of come back closer to normal. Emotional support from others. Instrumental support, which is like seeking advice, assistance, information. So you're kind of, again, it's a very active type of a strategy. And venting. And I was just glad to see venting was on the list. So that should I ever need to use that, it's a legitimate thing that is associated with better, less deviation. Let me just see. I think that was, yes. So this was just a fascinating thing to kind of associate and then to think about all the implications from the substance use to the active coping strategies and how this is impacting people's stress levels and ultimately their physical outcomes with their heart rate, their respiratory rate, sleep, physical activity, etc. All right, a few more slides, some on healthy relationships. So this is one of the pillars within lifestyle medicine. And this year, for this talk, I'm going to focus on loneliness and how that impacts relationships. There's been a lot of data coming out on this recently. The National Academies Press published this huge compendium about loneliness in older adults. And remember that slide we looked at that had the risk factors for death? And then kind of correlated that with different conditions. So we saw that nutrition, dietary factors was at the top, tobacco use was second, physical activity was somewhere down around 10, there was air pollution, a variety of other things. Well, what they did was they took a graphic like that, and then they tried to lay over it, and the writing is kind of small here, but they laid over it some of the things that fit into this loneliness and social isolation category, to just for us to be able to see how do these compare to other well-known factors. So you can see here that smoking in gray is the third bar down. So just in case you can't see that, smoking is the third bar down. Stopping smoking is the fourth bar down. But above that, the top two are social connection related issues. And that's the main point I want you to take away from this slide. Just the idea that social connection is very powerful. So all of the gray on here all of the black on here is social connection or loneliness factors. And the gray are leading health indicators that we're very familiar with. So you can see how powerful this is. And at the beginning, I said that nutrition is one of the areas and physical activity that we focus on the most because we think it has the most efficacy from an intervention perspective. But I think this area of healthy relationships and loneliness is one that we just don't appreciate. It may be just as important or more important. I mean, that's what this is suggesting than the other ones, but we just don't know enough about it yet. And its relation to other health conditions, to health outcomes, et cetera. And I think that's something that we really need to continue to dive into the literature and begin to understand better. So the group that worked on this said that they believe the risk levels are comparable to or greater than smoking, obesity, and physical inactivity, and that there is substantial evidence out there, even with the lack of evidence that we have, there is still substantial evidence available to point to the fact that social isolation and loneliness have increased incidences of major psychological, cognitive, and physical morbidities. The strongest evidence is for a link with premature mortality. So that's a very generic one, but premature mortality is a very final endpoint. So whatever gets you there, we need to do more research into those areas, but premature mortality is very sobering and recognizing that there's a connection there with loneliness. One specific study that was done, heart failure and social isolation. This group, Menaman and colleagues looked at this that was published in the American Heart Association journals. And they found that those who had high levels of loneliness had nearly 4 times greater risk of death than patients who self-reported low levels of loneliness. So that's a pretty significant difference between two groups of people. All right, our last pillar, avoiding risky substances and behaviors. So I think it's easy, the whole thing about just say no. It's easy to say, just avoid those risky substances and behaviors. But I think one of the things we could probably see throughout the talk today is how interrelated all of this is. Maybe the person had a significant life event, and so they're trying to deal with that, and they want to feel more normal. So there's a lot of reasons why people begin to explore and use these things as a way to cope in the first place. So ideally, we would say, just don't ever use a risky substance. But when you're already at that point where the risky substance has been used and the person has that or has a behavior that is addictive. Maybe it's gambling, maybe it's pornography. There's a lot of different things out there that are not just our nice little cut and dried, alcohol use disorder or methamphetamine use disorder. There's a lot more complex ways that people choose to escape from reality and the stresses and the things that are weighing on their hearts and souls. So we're going to focus today on a specific little aspect of substance use and behavior change. And it's about habit loops. So how habit loops impact our patients and some of the recent data that's coming out to help us understand that antecedent or cue, that might be the terms you heard, the behavior, and then the consequence or the reward. And obviously, addiction medicine is a much broader field than this. I think there was a lecture by some of my colleagues earlier that I heard went very well. So I'm so proud of them. But I'd love to share a little bit here about how we're learning how these cues and rewards can be mitigated. So mindfulness training is one of the emerging theories or practices to help retrain habit loops in our brain. So there's smartphone apps and other different, therapies to help people become trained in how to retrain their brain. And I do not have expertise in this. I have just read the article to share it with you. So I don't have a lot of details on that. But from what I did read, it kind of goes back and builds on the work of B.F. Skinner, who did cognitive therapy. And, he had I think it was rats and birds, and he would train them, and, he could teach them, if you push this lever, you'll get this reward. If you do that, you might get something that's painful or unpleasant. And so you could shape the behavior of these animals. And of course, my best example for myself is that my children are training me. When I take them to the store and they whine and cry, and then I get them a toy, they're very successfully training me to have the behavior that they would like to see me have, which is rewarding them with the toy. And, but on the flip side, I want to train them to say no. So as I was thinking of this, I was like, I was thinking about drawing like a graphic to go with this. And I was like, man, I think it's just a whole bunch of interconnected habit loops because we're all impacting each other, right? Each of our behaviors and responses and cues and rewards is something that plays into somebody else's habit loop at some point. So fascinatingly, they found that this mindfulness training, particularly when looked at with smoking, showed that it could decouple that cue or antecedent behavior reward cycle. It could begin to break those cues apart. And I think that one of the good examples of this is if any of you have worked with patients who are quitting smoking, they often will tell me, or I can ask them, so do you smoke when you drive? And they're like, oh yeah, absolutely. My car can't start unless I have a cigarette in my hand, or I can't, light a cigarette without being in my car. Those two, they're just inextricably linked. So this is a really fascinating thing to think about. How can we break these cue-induced couplings apart from each other? This mindfulness training therapy was 5 times more effective than cognitive therapy, which was also, I was like, wow, I need to learn more about this. I need to share more of this with my patients. There was also a little line in the paper that said that they'd begun to use it with some patients for weight loss and for food cravings, and that they were beginning to see some promise, but it wasn't the full article. So I was like, I need to keep following this and learn more about it. So in the study that this group worked on that I'm going to share with you today, they've done a lot of work in this space, but one of the things that they looked at was the posterior cingulate cortex. So do I have any neurology friends here today? Any neurologists? Okay. I'm sad because maybe this will be interesting. I'm glad because if I don't get it quite right because I'm not a neurologist, then maybe you won't know. So posterior cingulate cortex. This is where those habit loops or grooves for a behavior in the brain exist for people who smoke tobacco. It's not the only one, but it's one of the more important ones. And it's kind of where that default behavior of smoking is centered. So that link between smoking and driving your car, it's right there. So in prior research that this group did, the Jane's group did, they found that mindfulness training could reduce posterior cingulate cortex activity. So I'm going to call it the PCC from here on out. They could decrease the activity in the PCC with mindfulness training. So they said, could we use this to help people stop smoking? What would we see? What would happen with their PCC activity? So they started to look into this. So they used an app to deliver the mindfulness training over a month. So just 1 month time period to help them reduce the number of cigarettes smoked. They had an active control group. So this isn't just people that were left out there to do their own thing. The control group was assigned to a Quit Now program put out by the National Cancer Institute. So a decent resource to help them also quit smoking. Their hypothesis was that the mindfulness training would help reprogram the PCC to the smoking cues and that their participants would be more successful in quitting. So I will say, you can see here, excuse me, the results are not statistically significant, but it was a fairly small number. It was a pilot group. And I think from what I'm able to see, they were going in the desired direction with a reduction in the number of cigarettes. So those who were in the mindfulness training group reduced the number of cigarettes smoked from by 11.4 per day. So from a relative reduction of 11.4. The control group using the Quit Now guide reduced by 8.7. So maybe roughly a 3 cigarette difference. So I am fascinated to see if there's larger, more studies in the future that will show a statistically, significant difference, because in my mind, having worked with people over longer periods of time, 1 month is relatively short, I imagine this could be a really useful tool. So then they said, well, what happened with the PCC activity during this time? So they used some functional MRI and looked at that PCC activity and the number of cigarettes smoked. So they were trying to figure out if the PCC is less reactive, where all those habits for smoking sit, would the participant be more successful in cutting back on smoking? And the answer simply was yes. They found a statistically significant difference here, that the better that PCC was retrained, the more they would have results in terms of reduction in cigarettes smoked. I thought that was really fascinating. And then they shared a couple things that they have learned from their research. They said it's really important to find a better reward for the end of that habit loop. Trying to decouple the cue and behavior is key. And that curiosity, this was really fascinating. Curiosity is more rewarding to the brain than worry or craving. So they said that whole process of questioning, well, why am I doing this? Why am I picking up a cigarette right now? Why am I craving it so much? Why can't I turn my car on without having a cigarette in my hand? That whole process is very stimulating, very rewarding to the brain, and really helps to develop those new processes. So in summary, there's a lot of fun things, a lot of fun research in the world of lifestyle medicine and its 6 pillars. This is an important part of what we do as physicians in medical care, and has really important, relevant underpinnings to the risk factors and future disease in the range of 70 to 90% for non-communicable diseases. And I'm thrilled to have been able to be with you today. Thank you very much.